Good afternoon. Thank you very much for the opportunity to present our work. My presentation today focuses on in-hospital outcomes and long-term mortality of CABG using bilateral internal thoracic arteries, and we compared two different surgical approaches, the conventional on-pump approach and the anaortic off-pump approach. It is what we call CABG 2.0. It is an upgrade of the conventional approach, but we want to give the advantages of using bilateral internal thoracic arteries. An upgrade on that strategy is something we can call CABG 3.0 when we combine the off-pump approach, the anaortic, and the usage of two bilateral internal thoracic arteries. And our central question of our study was, does exclusive bilateral thoracic artery, when combined with the off-pump approach and anaortic technique, provide better clinical outcomes in the short term? And does it offer the same durable long-term survival? We performed a comparison between these two groups, and we looked at postoperative events and 25-year survival rates. Our study spanned over 2 decades, and we analyzed 412 patients who underwent exclusive beta, and 60% of them underwent off-pump approach. To minimize selection bias, we performed propensity score matching, and it yielded 158 pairs. We utilize survival analysis and Cox regression to identify independent factors of mortality. This table shows the good quality matching. We can see that both groups have very similar baseline characteristics. When looking at the surgical intraoperative data, we looked at number of grafts, which in both cases were similar. We looked at index of revascularization, which again was similar, and the conversion rate from off-pump to on-pump was relatively low. In terms of in-hospital outcomes, we again saw highly comparable results. 30-day mortalities was identical for both groups, and the other major adverse events were similar in terms of renal replacement therapy, deep sternal wound infection, stroke, tracheostomy, and reopening. They were all similar. The Kaplan-Meier curves showed that the survival trends over 25 years were again similar, with no difference in survival rates at 20 years. To understand what truly drives the long-term mortality, we looked at we performed Cox regression, and significant predictors of late mortality included advanced age, extent of coronary disease, and poor left ejection fraction. Importantly, the off-pump technique itself was not an independent predictor of long-term mortality. So, in summary, we can say that the usage of beta in an off-pump anaortic technique maintains postoperatively safety, although we were not able to demonstrate an advantage, especially over the stroke outcome. Our numbers were relatively small, so perhaps larger numbers are needed to demonstrate this benefit. Thank you for your attention.
Thank you very much. So you find no difference between two groups, actually. So what is their future strategy? So either you can select either procedure. So which procedure you decide?
Yeah, thank you. That's a very important question. I think it is very important to stress that the experience of the surgeon plays a very important role, and if the surgeon has the skill set to perform an off-pump and aortic technique, then we through this study we demonstrated that it's safe and provides the same long-term outcomes. Whereas if the surgeon does not have the skill set, perhaps it's better off to stick to the conventional strategy.
I thought maybe the only thing you find was advanced age and poor left ventricular ejection fraction is some kind of factors, affecting factors. So I think that if the patient is at advanced age, you can choose the op-cap, and if the poor left ventricular ejection fraction, you still can select the on-pump 2.0. Maybe.
Yeah, that's a great suggestion. Perhaps we can do a sub-analysis of the two strategies and see exactly within the two groups what are the different factors that influence.
Okay. So is there any question from the audience? Okay. Thank you very much.
Thank you.
Next speaker is Mr. Dr. Zander Jakimin from the Leuven. The title is Impact of the Distal Anastomosis Number and Graft Configuration on Midterm Outcome After Off-Pump Coronary Surgery. Please.
Okay, hello everyone. Thank you so much for the kind introduction. I'm here today to present the impact of distal anastomosis number and graft configuration on midterm outcomes after off-pump coronary artery bypass grafting from our center in Leuven. So, as a quick introduction, CABG outcomes depend on conduit choice and revascularization strategy as shown in these studies. Multiple arterial grafting offers superior durability, but it's not always feasible. And the clinical impact of performing more distal anastomosis in modern op-cap or mid-cap surgery remains unclear. As such, we aim to evaluate whether the number of the distal anastomosis targets influences midterm outcomes after op-cap or robotic-assisted mid-cap procedures in a single center in the contemporary era, and to compare between multi-arterial and any vein grafting strategies. So our study design was a single-center retrospective cohort study between 2015 and 2023, including over 2,533 patients, around 68 years old, and female were underrepresented at around 17.5%. Of these 2,500 patients, 674 were mid-cap procedures and 268, at around 10%, were hybrid coronary revascularization cases planned a priori. All op-cap procedures were performed by 7 surgeons from our center in either a skeletonized fashion for the IMA or pedicled. All robot-assisted mid-cap cases were performed by a single coronary surgeon. We looked at outcomes such as mortality, MACE, stroke, MI, and target vessel revascularization. So for the results for the configuration, almost 96.4% of patients received an LAD, target, 27.4% a diagonal, 24.8 circumflex, and as you can see in the table, you have in the columns if it was a single anastomosis, a double anastomosis, or a triple anastomosis on the distal target site. Then when we looked at the total distal anastomosis, we divided them in 4 groups, either a 1 total distal anastomosis, 2 distal anastomosis, 3 or more than 3 groups. And you can see the distribution of these cases here, and you can see that in the LAD, almost in all cases, was a target vessel. Then you have various distribution in the circumflex, in the diagonal, in the OM, or in the PDA, according to increasing amount of distal anastomosis. The median number was 3 in all cases, with an interquartile range of 2 to 3. When we looked at our vein grafting, we saw that over 1,000 patients, so 42.2% received any vein, with over 98.5% receiving a lima, 44% received a REMA, which was mostly in the BEMA setting, so 43.2% was BEMA. That takes that REMA into consideration. When we look at our subgroup of patients who received any vein grafts, we see that 51.2% received a vein graft from the aorta, and in total, so from the 2,500 cases, 46.7% received sequential grafting. So this is a very busy table, I apologize, but basically it shows some differences in the baseline characteristics between patients who receive a single distal anastomosis versus multiple distal anastomosis. You can see that as they receive more distal targets, patients are older generally, have higher risk, have more extracardiac arteriopathy. Another finding we did see is that some patients who have only a single distal target more often had prior cardiac surgery, so is the reoperative setting. So when we look at our perioperative outcomes, and I only took the one distal anastomosis and the more than three distal anastomosis to kind of make this a less busy slide, but you see that as the anastomosis increases, median hospital stay increases, which is tied to their frailty and higher risk, as well as median ICU stay, rehospitalization was lower in contrast, and reoperation increased. Our 30-day mortality was 0.29%, 30-day stroke was 0.19% in the overall cohort with no significant differences. So, but we were really interested in the long-term outcomes of these multiple distal anastomosis, and when we look at mortality, cardiac death, MACE, target vessel revascularization, we found only that as you perform more distal anastomosis, so as the patient needs more revascularization in the future, this is also a predictor for target vessel revascularization with a hazard ratio of 1.39. However, the other outcomes were not significant. Then when we look at the impact of any vein grafting, we see that multi-arterial grafting or total arterial grafting was associated with a significant lower risk for mortality, cardiac death, or MACE. And when we looked at the artery to vein ratio, which is for any artery, if they use one vein or two veins, we see that it is even after adjusting for baseline characteristics such as age, sex, comorbidities, we see that there's a 40% reduction per increase in artery to a vein, which is quite significant. Lastly, we performed an adjusted analysis based on the sites of the distal anastomosis to see if any sort of anastomosis had a significant effect on outcomes, but there is no significant findings here. So there's of course some limitations to present with this work. It's a retrospective single center study. The distal anastomosis count does not fully reflect coronary complexity, of course, and there's small subgroups in each cohort. And another limitation is that we do not have routine imaging to assess graft patency in these cases. In conclusion, what we want to say is that the number of total distal anastomosis does not affect midterm survival or MACE after long-term follow-up. However, there's a smaller increase in target vessel revascularization. Multi-arterial grafting was associated with higher survival and lower MACE than vein grafting. So it appears that conduit choice is more important than the total distal anastomosis number. Thank you. I'll take any questions.
Thank you very much. May I make it clear, even for the patient who received the one anastomosis, the patient has only single vessel disease or?
Correct.
So you mean that all patients had the complete revascularization?
Yes, but so it's based on their complexity. So if it was multivessel disease, they had multiple targets. So that's a limitation of the study as well. So this pools all of the patients. So
for the minimally invasive CABG, to make total revascularization for multivessel disease, you need mammary artery, also maybe vein. And if you use the vein, the long-term result would be a bit worse than the total arterial.
Correct.
Okay, please go ahead.
Yeah, so maybe it's connected to the previous question. I saw that for one anastomosis, there was higher rates of rehospitalization compared to more than three. is that maybe related to higher rate of hybrid strategy?
This is one explanation which we cannot account for, especially in patients who are more frail, who already had a reoperation. Those are the patients we target more for hybrid reoperations, and that's a good point.
Thank you.
Thank you.
Okay, wonderful result. Thank you very much. Thank you.
Thank you.
Okay, the next presenter is Dr. Dong Yong Han. Outcomes of multiple versus single arterial coronary artery bypass grafting in multivessel disease with left ventricular dysfunction. So please start the presentation.
Hello everyone. My name is Dong Yong Han from Asa Medical Center. And it's a great honor to be here today. And I will present the outcomes of multiple arterial grafting versus single arterial grafting in patients with multivessel coronary artery disease and significant ventricular dysfunction. In the general CABG population, MAG has consistently shown improved long-term outcomes. A recent large-scale analysis of isolated CABG published in the Annals of Thoracic Surgery reported that MAG provides a significant long-term survival benefit compared to SAG. However, the benefit of MAG remains controversial in patients with poor ventricular function. Therefore, we aim to clarify whether MAG truly provides a clinical advantage over SAG in this high-risk subgroup. This was a retrospective single-center analysis conducted at Asa Medical Center from 2000 to 2024. We included patients undergoing isolated CABG with or without mitral valve surgery for ischemic MR, and also with or without surgical ablation. Our primary outcome was all-cause mortality or heart transplantation. Secondary outcomes included lipid revascularization, myocardial infarction, heart failure, which required rehospitalization, and stroke. And to adjust for baseline imbalances between groups, IPTW adjustment was used. After applying the exclusion criteria, 425 and 297 patients were included in the SAG and MAG group, respectively. And here are the baseline characteristics of study cohorts. As you can see, there were differences between the two groups before adjustment in terms of age and comorbidities, including dyslipidemia and ESRD. And as well as hemoglobin and albumin level. After IPTW adjustment, a balanced cohort was analyzed to compare the treatment effect. And in the MH group, many patients received the lateral arterial grafting CABG. Lima and gastroepiploic artery were also used. There was also a marked difference in the number of anastomosis, with MAG having more distal anastomosis overall, and nearly half of the patients receiving 4 or more anastomosis in MAG group. Next are the clinical outcomes. In the early outcomes after adjustment, there were no significant difference in other variables, but the risk of low cardiac output syndrome was significantly higher in the MH group. And in the overall outcomes, mortality or heart transplantation was markedly less frequent in the MH group, while the myocardial infarction and revascularization, heart failure, and stroke did not show substantial difference between the groups. But the mortality or heart transplantation composite differed significantly less in MH group. And also, because the number of anastomosis differed considerably between the two groups, we also examined how mortality varied according to the number of anastomosis within each group. Notably, in the subgroup with fewer than 4 anastomosis, MAG demonstrated significantly lower mortality, suggesting that the disadvantage associated with SAG may be more pronounced in patients receiving fewer distal anastomosis. So this is the conclusion of our study. In patients with LV ejection fraction less than 35%, CABG using multiple arterial graft was associated with a significant reduction in death or heart transplantation. Thank you for your attention.
Thank you very much. Okay. You treated a very high-risk patient. And
Janusz Konstanty, cardiac surgery, Kraków, Poland. Congratulations, very nice presentation. I have one question because we have a statistically different number of grafts between these groups, yes? Did you check the completeness of vascularization? Because in a patient with low ejection fraction, completeness of vascularization, this can be this probably the key for the better results. So what about the completeness of vascularization? It means, did you do all grafts you planned, and this is the difference of the number of grafts you did, or you do not do the completeness of vascularization? What is you have 100% of completeness of vascularization in both group?
I'm sorry.
I mean, if you have a patient and you plan to do the 3 grafts, you do the 3 grafts. If you have a patient, you are going to do the 4 grafts, you did 4 grafts in
yes.
all patients, yes?
No, we don't the total revascularization routinely.
so the question is, the number is different for the total arterial grafting and the group, but both group are complete revascularization.
Yeah, this is the question.
Well, maybe because of the merged arterial grafting, the anastomosis number is less.
Yeah, it's lower in one group.
So that's the question. So both groups, basically you do a complete revascularization or not?
Or that. We didn't do the routinely total revascularization.
So it means by using in combination with the saphenous vein graft, you anastomose much more. No.
Yeah, I understand that because this is the key problem in arterial vascularization. You should do the complete revascularization. It means you have to do the grafts to all branches which it should be grafted, and this may get different it may affect the long-term follow-up and mortality.
So your point is that because of this is a very dysfunctional myocardium, as much as possible anastomosing, then you get a much better ejection fraction after.
That's the point.
So the main, which is the main message? It's an important thing. Number of the graft is important, or the graft selection is important. Which do you think?
The main message is graft selection was important.
Okay. Thank you.
Thank you.
Okay, next speaker is Julia Umekita Mitsutani from Sao Paulo. The title is Trend in the Use of the Multiple Arterial Grafts in Myocardial Bypass Surgery After Becoming a Quality Metric in a Reference Center in Latin America.
The mouse. I don't know why. Okay. Thank you.
This is you?
Yes.
Okay.
Okay. Thank you.
Okay.
So, good evening. My name is Julia. I'm a 4th-year medical student, and today I'm here representing Concurrent, a heart center in Brazil. And I'm here to present the study Trend in the Use of Multiple Arterial Grafts in a Myocardial Bypass Surgery After Becoming a Quality Metric in a Reference Center in Latin America. So, although the use of multiple arterial grafts is linked to better patient outcome and better patency, its use is still limited in various centers. As you can see, the average use doesn't surpass 25%. So, our aim here is to analyze how this technique was used in a center in Latin America after it was considered a quality metric. We analyzed our institutional database to assess how this technique was used in patients that underwent CABG in 4 different time periods from 2016 to 2024. We excluded emergency surgeries as well as reoperations and procedures that occurred in 2020 to the COVID pandemic. Also, it's really important to highlight that since 2018, the use of multiple arterial grafts was implemented as a metric for our coronary artery surgery unit within our continuous improvement program for institutional quality. So we saw 4,756 procedures resulting in more than 13,000 grafts, majority of them being arterial and averaging 2.85 grafts per procedure. We can see on the graph in blue that the use of multiple arterial grafts raised substantially, going from less than 14% on the pre-implementation period up to almost 50% on the third. We can also see the use of radial artery raising substantially, going from less than 6% on the pre-implementation period up to 37% on the fourth. The use of bilateral mammary artery also rose, going from 9.66% up to 13.05 on the third. So overall, we saw an increasing upward trend in the use of multiple arterial grafts, reflecting our adherence to current guidelines. By including this metric within our program and that being followed by a shift in the use of grafts, just shows our commitment to continuous improvement and to state-of-the-art myocardial revasculating surgery. Thank you.
Thank you very much. She is a medical student, but she reported very well data from the Latin American database. So may I ask, the data came from only your institute or all center?
Only the center, the institute.
Only your center?
Yes.
Okay. And you said the ratio of the multiple arterial grafting is increasing, and meaning that mainly using the radial artery rather than the bilateral mammary. Any question from the program? So in the Latin America center, in her institute, the trend for the multiple arterial grafting is increasing and becoming unpopular. Any comments? So maybe it should be a difficult question for you. Why did you choose radial rather than bilateral mammary artery?
Well,
I'm sorry.
It's okay. No, as I learned, it's just it's my mentor. He's here as well if I need help. But
Thank you.
As I learned, at least that radial artery is the surgeons have more facility to harvest, and also 1/3 of our patients are diabetic. So harvesting both mammary arteries would increase infection rates and such. So.
You run very well. You studied.
You have any comment or not?
No, she answered very well your question. I think we have a major problem with wound infections, so it's very easy to harvest the radial artery, and we do it every day. It's easy to teach the residents. We have 25 residents in our institution, so they harvest the grafts there.
Yeah.
So I think she answered perfectly the question.
Maybe, please.
I was just about to ask, who harvests the graft?
Well, yeah.
In U.S., the physician assistant, so I'm a radiographic PA, so I do radial harvesting
Okay.
and vein harvesting. So that was my question, which you answered.
So yeah, we don't have PAs in Brazil at least. So all the residents, they are trained to harvest all kinds of conduits, even it's a phenol vein graft, radial arteries, and lima and the rima as well, and right gastric plug. So that's how we do. We do open because it's very expensive to have the devices in Brazil. So I used to train one with the Getting, but they're not replaceable anymore. So we're just using the regular incisions.
Of course, I know that American guideline recommended the radial artery for the first time. American guideline recommended the radial, but personally, I prefer bilateral mammary. How do you think about, in your opinion?
Well, I like both. I like total arterial for sure, especially for younger patients. For over 75 years old, I don't think a saphenous vein graft is a bad conduit at all. I think that it has enough patency to keep them alive for 10 to 15 years without any events. But I think that working with radials is very easy. They're bigger and easier to harvest. It's fast to do it, to manipulate. But I do BIMAs and radial as well. So
okay, thank you. Any comment from you? It's okay? Yeah. Okay, very good.
Thank you.
Thank you very much.
So let's move on next presenter. Next presenter is Dr. Maria Comaneci. Okay, exclusive bilateral internal thoracic artery versus left internal thoracic artery plus radial artery revascularization in diabetic patients, a comparative analysis.
Thank you once again for the opportunity to present. Our work actually follows on what's been just mentioned now. And through this study, we wanted to look in our diabetic cohort of patients, and we know that arterial grafting is of great benefit for all patients, and especially diabetic patients also benefit from multiple arterial grafting and total arterial grafting. However, the adoption of this strategy has received quite a lot of resistance, and mainly due to concerns of sternal wound infection. So we looked at total arterial grafting in diabetic patients using exclusive beta on one hand and LITA plus radial artery on the other hand. And through this analysis, we wanted to evaluate the clinical outcomes and long-term mortality. So we again looked at our database, which spans over 20 years. We had 262 diabetic patients who received total arterial grafting, and we can see that 100 of them received beta, whereas 162 received LITA plus radial artery. We again employed propensity score matching and Kaplan-Meier and Cox regression. We looked at a lot more variables, but this table demonstrates that after propensity matching, we were left with 94 pairs with no significant differences in preoperative characteristics. In terms of intraoperative data, 55% of the patients in the beta group were done off pump, and 54% in the LITA plus radial artery group were done off pump. There was no difference in the number of grafts, and there was no difference in the index of complete revascularization. When we looked at in-hospital outcomes, the results actually took us by surprise. There was no difference in the rates of reopening for bleeding. However, the deep sternal wound infection rate was significantly higher for the LITA plus RA group, which was 8.5% versus 1.1% in the beta group. And the mortality rate at 30 days was higher in the LITA plus radial when compared to the beta group. In terms of 25 years survival rates, in both unmatched and matched comparison, there was no difference at 20 and 25 years. We looked at the main factors that influenced both the deep sternal wound infection and long-term mortality, and we didn't find any strong predictors. The CETA plus radial was a strong predictor in the univariate analysis for deep sternal wound infection, but it didn't maintain its statistical significance in the multivariate analysis. When we looked at predictors for long-term mortality, we didn't identify any strong predictors. So the key findings, it was, as I said, the higher rates of sternal wound infection was contrary to what the literature says in our experience, and the early mortality was also higher in the LITA plus array. It is important to acknowledge the limitations. This is a single-center retrospective analysis with relatively small number of patients. Our database does not reflect the technical strategy of the LITA or RITA harvesting, which is known to influence the deep sternal wound infection risk. And we don't have the data on the diabetic control parameters, which is also a very important aspect of it. Thank you for your attention.
Thank you. Okay.
So very interesting. Congratulations. So just one question: the rate of infection in the LITA plus radial artery group of 8.5% seems to be very, very high. So can you comment on this? Do you have any reason for this?
Yeah, thank you for your question. I think it is important to stress out that this is in the diabetic cohort of patients, which are known to have higher rates of sternal wound infection. In our whole cohort of patients, when we looked at our total numbers, the rates were not this high at all. That's why the data raised some questions to us as well.
Thanks.
I think the result is different from your expectation, probably. So that's why you mentioned maybe it was related to the harvesting technique or the level of the diabetic mellitus or the hemoglobin A1C. You didn't analyze that kind of number.
Yes, that's correct. On the other hand, I would say that this data also came as a reassurance that bilateral mammary arteries in diabetics is quite safe and it can be offered to patients. But of course, if we had data on the strategy, the harvesting strategy would have been much better.
Please do the next step study.
Yes.
Thank you very much.
Thank you.
So again, Maria, we present CABBAGE Prime study and exploratory prospective study on platelet function testing and postoperative outcomes following coronary artery grafting.
Thank you very much. This presentation has got a slightly different format and would be very nice to discuss it and see your perspective on this subject. The presentation is about using platelet mapping to guide postoperative antiplatelet management after CABG. This study was funded by our charity, for which we are very grateful. And we know that antiplatelet therapy is very important for patients after CABG. However, a problem that perhaps is not discussed enough is antiplatelet resistance, basically resistance to aspirin or clopidogrel. And currently, we prescribe these medications based on one-size-fits-all. But we know from the literature that up to 40% of patients show resistance to these drugs. We published a meta-analysis looking at this exact dilemma, and we found out that 1 in 3 patients do not respond well to aspirin and or clopidogrel. And what is even more concerning was that this suboptimal response to medications was indeed translated to higher rates of mortality at 1 year and higher rates of perioperative myocardial infarction. The current guidelines do not recommend routine testing and do not recommend using these tests to guide antiplatelet therapy. The only recommendation about the usage of the testing is to plan the timing of the surgery, which we are doing at our institution currently. However, we wanted to see if these same tests can help us guide antiplatelet medication for patients post-op. So our primary objective through this study was to assess if there is a correlation between platelet function test results and clinical outcomes in CABG. And we also want to see if there is indeed variability in platelet function among patients as it is described in the literature, and see if there are certain demographic factors or any other clinical factors that are associated with these results. So for us, it is a prospective single-center study. We are very much in the process of it is still in the process. Our target is to enroll 100 of patients, and the total follow-up is 12 months. We have many means to test platelet reactivity. There are lab-based tests, there are point-of-care tests. At our institution, we are utilizing TEG platelet mapping, which they have got different cartridges, and we can look at the arachidonic acid assay that tests that reflects the inhibition caused by aspirin, and the ADP pathway, which reflects the effectiveness of clopidogrel, ticagrelol, prasugrel. So how we're doing it, we are approaching patients who are planned for CABG, and if they do consent to take part in our study, we perform a baseline test to establish their responsiveness before surgery. We test again before discharge, and we at 6 weeks of follow-up, when they come back in our clinic, we test. We do a platelet mapping test again, and the final follow-up it will be at 12 months. We have over 52 patients that are enrolled, and I'll just show an example of a patient because we don't have any data yet. This is a patient that came to us for CABG. We can see that on both assay, arachidonic acid and ADP, there was minimal inhibition, which reflects this patient was not respondent to either aspirin. Well, at that point, he was on aspirin only. Before discharge, we repeated the test again. We again see that this patient was a very poor respondent to aspirin and clopidogrel. And at 6 weeks follow-up, after he was well established on dual antiplatelet therapy, he again stayed a very poor respondent. So there is a problem that we need to address, but at the moment we are not sure if and how we need to do that. I think I'm above the time, but our main goal is to answer this question through this study, and hopefully next year we'll have some data to present. Thank you very much.
Thank you. So you assess the platelet function by using the TEG. And I think that the TEG has many parameters of the platelet function. So which parameter do you want to focus on?
Sorry.
Which parameter do you focus on?
Parameter.
Yeah, parameter.
Parameter. Which kind of parameter?
Yes, so the
Adhesion or some. I'm not sure about that, but I don't remember that.
ideally we would use a lab-based test that would be more accurate with higher specificity, with higher sensitivity. But for the purpose of this study, the TEG platelet mapping was the most convenient for us.
Okay.
So it is quite convenient because it gives us results in terms of percentages. So we can say 50% of the platelets are inhibited or not, or 0% of platelets.
And also, all patients receive same protocol of anticoagulation, antiplatelet therapy after operation.
This is an observational study, so we're not making any intervention. It is completely up to the clinical team. So it depends on what the surgeons prefer. But most of our patients are on dual antiplatelets.
Yes, I'm Ziad Bunga from Lausanne University Hospital in Switzerland. Nice presentation, but I can't get where you're going with that study because there are many things which are quite weird. The first thing is that the actual European recommendation is what you didn't mention is cabbage after cabbage. It's not double anticoagulation unless it is acute coronary syndrome. This is one thing, and you didn't mention among your patients how many patients is after acute coronary syndrome, which really benefit this double anticoagulation. This is one thing. The second thing is, what is your expectancy of patient, or the probability of having patient being do not respond to clopidogrel or aspirin? I think it's going to be very poor. We are doing that for years now, and I can assure you that I've seen only one guy, only. But good try.
I'm sorry, we are running short of time. Okay? Comment. Thank you very much.
Thank you so much.
Okay, every presentation is very interesting, but the presentation is limited only 4 minutes and the discussion is 2 minutes. Otherwise, we lose time, finally. So please move on next presentation. And Dr. Tarun Rajasekar. The title is a 20-year comparative analysis of single and multiple arterial grafting in severe left ventricular dysfunction. So.
Good afternoon and thank you for the introduction. Today I'm going to be presenting a 27-year comparative analysis looking at survival outcomes of single and multiple arterial grafting in patients with severe left ventricular dysfunction. Now, as you all know, coronary artery bypass grafting represents the gold standard surgical intervention for multivessel disease, and particularly patients with impaired left ventricular function. Lima to LAD continues to be the most prominently used anastomosis. However, more and more studies have been investigating multiple arterial grafting, as has been reiterated multiple times over the last few days. So a lot of studies are looking at multiple arterial grafting, particularly bilateral internal mammary and radial arteries, due to a proposed survival benefit and improved patency. Despite this, there's been an underutilization in patients with severe left ventricular dysfunction, and this is largely due to concerns regarding the operative complexity and incidence of sternal wound infections. Despite this, there have been studies looking to mitigate these risks, such as through skeletonization of the mammaries and a selective utilization of radial artery for target vessel stenosis. The aims of our study is to investigate the short and long-term outcomes of survival for multiple versus single arterial grafting, as well as identifying individual predictors for mortality. Now, in terms of our methodology, as you can see here, we performed a retrospective single-centered analysis of 489 patients over a 27-year period. And the single arterial grafting group was predominantly consisted of patients with left internal mammary arteries alongside saphenous vein grafts, while the multiple arterial grafting group was predominantly patients with bilateral internal mammary arteries. And as you can see here, we did a one-to-one propensity score matched analysis using a nearest neighbor algorithm, generating 121 patients in both the single and multiple arterial grafting groups in order to mitigate any baseline imbalances. And that can be corroborated here with our love plot, which shows good balance amongst the covariates. Now, in terms of our preoperative characteristics, in the unmatched cohort, as you can see, there's an increased incidence of cerebrovascular disease in the single arterial grafting group and an increased incidence of ex-smokers in the multiple arterial grafting group, but these were then mitigated following propensity score matching. In terms of our short-term outcomes, as you can see, there's no significant difference in short-term outcomes across both the unmatched and matched cohorts. However, there was a significant difference in the mean follow-up time in the unmatched cohort, which was then mitigated in our matched cohort, allowing us to have a more balanced longitudinal analysis. Now, interestingly, when you look at our long-term survival outcomes, there's a numerical advantage in multiple arterial grafting in both the unmatched and matched cohort, and a statistically significant one in the unmatched cohort, which is then mitigated in the matched cohort. And that is largely due to selection bias, but more on that in a few more slides. In terms of our independent predictors, as you can see, age was a consistent predictor for mortality across both the single and multiple arterial grafting group. And rather paradoxically, the ex-smokers was a predictor for mortality in the multiple arterial grafting group. So what does the literature say? So I'd like to bring your attention to two different studies. So a study performed by Zhang, which did show improved major adverse outcomes in the multiple arterial grafting group compared to the single arterial grafting group. However, they didn't investigate patients with severe left ventricular dysfunction. Another study by Ren actually did show superior survival in multiple arterial grafting across different stratifications of ejection fraction. But interestingly, when the analysis was limited to total arterial grafts, this survival benefit was lost. So what does all of this mean? So in terms of age being a predictor for mortality across both these groups, it shows the progressive atherosclerosis effect and endothelial dysfunction over time. And in terms of ex-smoker being a predictor for mortality, that shows the progressive cardiopulmonary effects of smoking, which isn't negated once we stop smoking. So all this points towards the fact that it's important that we understand the biological interplay and the interplay between comorbidity status and biology, and conduit configuration isn't everything, and it's not just about these intraoperative outcomes. In terms of selection bias being a kind of influence in our matched cohort, that shows the importance of an individualized conduit strategy and how it's important that we look at it at a patient-to-patient perspective rather than generalizing it to everybody. And that brings me on to my final point, which is to move away from a one-size-fits-all strategy and take a more holistic assessment of the patient. Thank you.
Thank you very much. So this is a very severe group, less than 30% of the ejection fraction. So, okay, did this patient have any kind of functional mitral MR?
Sorry?
Functional mitral regurgitation. Mm-hmm. Did you mention about that kind of?
Yeah, so unfortunately I didn't actually investigate the functional mitral regurgitation, but that's definitely something that we could include in a further analysis, so thank you for your question.
Okay. And the previous presentation, the number with the anastomosis might be important than graft selection. So how about your anastomotic numbers for each group? And maybe I missed the number.
So in terms of the index of revascularization, all the patients had greater than 1, basically.
It means complete revascularization.
Yeah.
Okay. So okay. So it means for the unmatched groups, maybe some kind of selection bias exists because of the survival difference.
Yeah.
But the matched group, they're almost the same.
Yeah.
So your strategy forward? So what kind of strategy you will choose after this study? If the patient comes less than 30% of ejection fraction, so which patient do you pick up a single arterial graft? Which patient do you pick up a multi arterial grafting?
Well, I think there's quite a few factors into play in here. So one is surgical preference is quite important. I think what surgeons are comfortable with would also improve their outcomes. But I think it's very important that we have an individualized conduit selection. So maybe for a younger patient, it might be more suitable to have like a multiple arterial graft compared to an older patient. And then also ex-smoker was a factor.
So you mean the life expectancy of the patient is kind of...
and also the comorbidity status of the patient.
Okay, thank you very much.
Thank you.
Next speaker is Dr. Massimo Baldo from the Locarno Medical Center.
Okay. So, good afternoon, everyone. I will be talking about configuration strategies for multi-arterial coronary artery bypass grafting, insights from our highly specialized center in coronary vascularization. These are my disclosures. So, a little bit of introduction. As we all know, and how it is repeated many times also in this Congress, multi-arterial grafting are associated with better long-term patency rates, clinical and surgical outcomes. However, their adoption rates worldwide is quite limited. Therefore, we thought to analyze our different configuration strategies in our center, considering we are highly specialized in coronary revascularization. Therefore, we retrospectively included all our sternotomy multi-arterial CABG from our center from July 2021 to December 2024. And there were a total of 218 patients, which corresponds to roughly 63% of all the sternotomy cases. Patients were quite young, 64 years, mostly male, not too high risk, and you can see all the preoperative characteristics on your left, and ejection fraction was 58%. Now, diving into the more important data, looking at the type of revascularization strategies, almost 90% of the procedures were performed off-pump, with a minority of on-pump beating and completely on-pump, only 2 cases. Looking at the different conduits that were used, 30% roughly were total arterial, and the use of LITA was basically all but 1 patient, RITA 50%, which means that the beta rate was 50%, 70% of radial artery, and 67% of composite grafts, mostly I graft and Y graft. Piggyback was performed around 45% of the patients. So looking at the outcomes, the most fearful complications, stroke, deep sternal wound infections, bleeding, and mortality rates were very low. Looking so more in detail about the different configurations, the most frequent one was an in situ RITA extended with a radial artery or a vein, most frequent one with 43%. This could either be targeting a single coronary or in sequential multiple coronary arteries as depicted in the image on the right. This was followed in frequency to the piggyback of a radial artery on the aorta, around 37%. Y graft, including both, including LITA, RITA, radial artery was about 20%, and finally the simple in situ RITA was about 4.6%. Sorry. So, in conclusion, in highly specialized centers, the number of multi-arterial, especially total arterial, are very high. We know that these are associated with better patency rate and outcomes. Indeed, our beta rate was 50%, and the most frequent configuration was RITA extended with either an artery or a vein. Combination strategies, of course, should and are highly suggested to improve the efficacy. Thank you for your attention.
Thank you very much. The paper from the Jean-Luc Institute, and he said that elongation using the radio and the inside lighter is most popular in your institute.
Yes, it is.
Yes.
Yeah, exactly.
Very interesting. Okay, please go ahead. Please use the mic.
Albert from Germany. I have two questions. First, you really think that it's safe to extend the right mammary artery with a vein? Or perhaps you have some experience with this? Because there's a caliber difference. I would like to have your experience. Or is there systematic controls?
Yes, indeed, there is caliber differences. There are techniques try to match it. Till now, we didn't see particular differences in outcomes, including thrombosis of the grafts. Even probably in those cases where the vein is used is because the artery was not that good to elongate the reta. We still believe that the benefit of the artery, the right internal thoracic, it still gives to the coronary that is anastomosed through the nitric oxide and so on.
Okay, second, you think it makes a difference, which is if you do a sequential graft with this extended graft, which vessel is at the end of the sequence, if it's a vessel with more severe stenosis or less severe stenosis?
Exactly, that is extremely important questions. So in the most frequent configuration of the reta, the most stenosed is always the last one for competency of flow. So depending whether it is the OM or the right, it goes through the transverse sinus or from the obtuse, so one way or the other.
Okay. Anyway, there are many variations of the configuration, so we should think about which is better and the best. Okay, thank you very much.
Thank you.
So the next presenter is Dr. Janusz Konstanty. Okay. Okay. So the title is Skeletonized Internal Thoracic Artery Using Diathermy and Effect on Flow Rate.
Welcome everyone. My name is Konstanty Kandek. I'm a cardiac surgeon from Poland, Kraków, and I will show you some our study about the flow after skeletonized internal thoracic artery harvesting. We discussed, there was a lot of, today also a lot of lecture about beta and radial artery and harvesting, and we should, everybody encouraged to use more arterial vascularization. But we have to think about the flow after, which is very important to do, to check it after procedure, and about the spasm. First of all, a few words about this flow and the system transit time flow, which is routinely used and should be routinely used after every CABG procedure. And it is also a recommendation from the guidelines. This is a very nice paper from Dr. Taggart and Dr. Teresa Kieser about how to use it, transit time flow meter, and what are the numbers. The numbers are now different a little bit. We think that over 20 should be okay, and positive index about 3. But I want to underline one thing that in this publication, the authors suggested it should be a few measurement during the procedure, not only one measurement at the end of the surgery. Other thing is that if you use the site to skeletonize the internal thoracic artery, so there's some suspecting and some surgeons afraid it can be a spasm, or because when you're using the diathermia and when you harvesting data, and there are some publications that this path can be reversible, and on the other hand, papaverine, which is routinely used in our department to prevent the spasm and to make this flow better after harvesting. So we decided I checked our results. This is a part of our study. I don't have a full results, but we included for now 31 patients, and we harvest the skeletonized harvested internal thoracic artery, left or right, wherever, and then we use the papaverine around. There are some few options, some discussion which is better to put inside or around, wherever we use on the sponge. We use papaverine around the harvested artery. So first of all, we make the first measurement before harvesting, just in the very beginning. Then we check it after harvesting, and then we put the papaverine, and then we measure it again, and then we did the last measurement after graft. So the two primary results. First of all, is skeletonized mammary using diathermia have some effect on the internal thoracic flow? Yes, it has. It decreased significantly, but after use the papaverine, we have the proof that after use the papaverine, the flow measurement increased basically to the same level as we checked before. And the second question is, we observed that it can be, there's a small number of patients, but it can be some dependencies between flow in mammary before and mean flow after grafting. Other words, if we have a good mammary, we will have a good flow in a graft. If we have a poor mammary artery and poor flow because of the anatomy, because of the situation, we can have a lower flow in our graft after surgery. Okay, so just two words: spasm is temporary and can be reversed by using a papaverine. And the second thing is another thing which we can think about when we make a measurement, that can be some dependent between the flow before the flow in the native IMA and the graft done by mammary artery. Thank you.
So you mean the graft flow that before harvesting you put the problem on the not the before anastomosis.
We did before harvesting. Let's say open the chest and make a small incision and check the flow, and then I harvest skeletonized way, harvest the mammary artery, not cut it, but check the flow in native mammary artery and check the flow. Then we put the papaverine, wait 15 minutes, and make another measurement without the cut off. So to check how it's look, how the mammary will behave after papaverine.
So this data is not related to the coronary artery, just
mammary artery, yeah. Because we are talking about mammary artery using in a coronary graft.
Okay.
Yes.
So, okay.
Yeah. Would it be effective for you, because you are putting an assertion that diathermia is going to decrease the quality of your mammary artery? Wouldn't it be better to compare it with a control group whereby you're using plasma jet or something else like harmonics, and this will significantly show that we could have something comparable? Now we are comparing a flow against another flow with diathermia.
That's true. You have absolutely right. I'm smiling because in the beginning of the study, we wanted to compare these two techniques, like a harmonic scalpel and diathermal scalpel, but we had some temporary problem with the harmonic scalpel at our institution. But we have a data, and probably in a few months I will show the data comparing these two tools to harvesting, like diathermia versus harmonic scalpel. Yes, but this is very, 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 very point. Yeah.
Okay, thank you very much.
So next speaker is Bichin Chandra from India. The title is A Novel Technique of Internal Mammary Artery Harvesting.
Thank you, sir. Chandra.
Yes.
Yeah. Thank you.
Okay. So slideshow.
So, topic is novel technique of internal memory harvesting. Myself, Bipin Chandra from India. Coronary artery bypass grafting, usually using internal memory artery, remains gold standard for myocardial revascularization. Literature has highlighted the development of surgical procedures approaches with studies investigating optimal selection of arterial conduits and arterial harvesting. Approaches, techniques, and conduits have their advantages and disadvantages. I have done only 15 cases, a short study over a period of 8 months. This aims to explore the efficacy and advantages of new technique of internal memory artery harvesting. IMA harvesting procedures like with electrocautery or with harmonic causing spasm, waviness, subadventitial hematoma, tissue damage due to blunt hot dissection of tissue planes during harvesting by it has been recorded. Later on, introduction of harmonic scalpel has reduced thermal injury and spasm and use of clips. To achieve nearly perfect lengthy IMA with terminal branches, technique of sharp cold dissection using conventional number 15 blade and clips with probing of terminal branches only was used without use of topical or intra-arterial chemical vasodilator. So IMA harvesting with this technique using conventional number 15 surgical blades yields a spasm-free, straight, injury-free, lengthy IMA with its terminal branches having very good flow. So this is proximal harvesting by proximal IMA is harvested by this is scalpel, number 15. Mm-hmm. This one is distal. This is IMA with its branches like musculophrenic and superior epigastric. And this is the measurement, the yield of the length. This is 15 centimeter and another is 15. It's more than 30 centimeter. Only using one branch like superior epigastric. The other one is still there. And I'll show you the flow. This card, small paper cards, they are used to prevent the twisting of the branches. So in conclusion, IMA harvesting by sharp cold dissection technique using number 15 surgical blade yields a spasm-free, straight, injury-free, lengthy IMA with its terminal branches having excellent blood flow, which are used for sequential grafting with varied configuration. I used this artery for revasculating all three territories, anterior, lateral, and inferior, by only using IMA Lima with its branches. No radial, no saphenous vein, no rima, no superior epigastric, gastroepiploic, and aorta was untouched. Thank you.
So it is new or very classical, or I don't know, but you don't use the diasami and no harmonic scalpel, just using the 15 blade and dissector.
Yeah.
Very good. Any questions? Okay, please go ahead.
So I had one question. I was wondering about the blade. Have you had any injury to the IMA using the blade?
No. You have a very sharp dissection. You can see everything. You don't have dissect bluntly. The cautery is a blunt, harmonic is a blunt.
Yeah.
You need to go with plane between this periosteum and IMA. So a sharp blade is more helpful in that and more graduated.
Thank you.
So if you injure the vein, how to stop the bleeding? Clip the vein, and I think there's some small bruising or bleeding from the fat tissue or something. You don't just.
Yeah, it doesn't worry.
Okay.
Very interesting. By the way, what was the body mass of these patients? You harvested those very long and beautiful and pulsatile, because my average patient, I am an Italian surgeon, Luca Velter from Rome, is a very short lady, very fat one, and even the terminal part of the main part of LMD is 1 millimeter at the very best. So are we talking maybe bigger patients?
No.
No?
Indian patients are also small, like Italian one.
Exactly. I was looking at you and saying,
yeah.
Okay.
Okay.
Okay, thank you. Thank you very much.
Okay. Next presenter is Dr. Massimo Baudo. Okay. The title is Minimizing Stroke Risk in Off-Pump Cabbage, the Role of Clampless Devices and the Piggyback Proximal Anastomosis Technique.
So, good afternoon, everybody. So, the presentation will talk about how to minimize the stroke risk in off-pump cabbage and the role of the clampless devices and the piggyback proximal anastomosis technique. So, those are my disclosure. So, stroke is the single most disabling complication in cabbage and can really nullify the benefits of myocardial revascularization. And since the syntax trial showed a stroke rate of 2.2%, we have done everything to decrease the aortic manipulation and the stroke rate. So several techniques are very useful for these, like single cross clamp to complete all the proximal anastomosis, aortic off-pump cabbage, and the use of routine CT scan and epiaortic ultrasound to evaluate for the aortic calcification. And in our practice, we try to do as much as possible aortic off-pump cabbage. However, sometimes proximal anastomosis are still required. So we think that two techniques are very useful as a complementary technique when you cannot avoid proximal anastomosis. And one is the use of clampless devices to construct the proximal anastomosis. In our practice, we either use heartstring or enclosed tube. And the other one is the piggyback proximal anastomosis technique, in which you are put one conduit over the other one with one single hole on the aorta. So our study enrolled 112 consecutive patients undergoing cabbage with piggyback proximal anastomosis and the use of clampless devices, as I said, had either heartstrings or enclosed tube between June 2021 and January 2024. Our primary endpoints were the overall mortality, cardiac-related mortality, stroke, myocardial infarction, and repeat revascularization. And we also analyzed transit time flow measurement, TTFM, as a secondary endpoint to see if there were any difference between the conduits. So as you can see, our population was 75% male, the mean age was 68, and everyone received off-pump cabbage with an average number of anastomosis of 3.4. A second anterior conduit was used in approximately 60% of the patient, and the radial artery was the most used one. Of note that 29% of patients also receive left atrial appendage closure with AtriClip. And for what concerned the piggyback composition, vein-on-vein configuration was used in 52% of the cases, artery-on-vein was used in 43% of the cases, and the configuration with a double vein with an artery on top was used in 3.6% of patients. So 37% of patients were able to be extubated in the OR, and at 30 days, no stroke, no death, and no repeat revascularization occurred. The mean hospital stay was 5.5 days, and at 1 year follow-up, the overall survival was 98%, and the repeat revascularization of one of the graft coming from the piggyback was 3.6%. As secondary outcome, also at the TTFM, the configuration of the artery on vein showed a statistically significant difference compared to vein on vein configuration. In the first one, we had a mean flow of 50 ml per minute, whereas in the vein on vein configuration, we had a 40 ml per minute. So as a take-home message, when a proximal anastomosis cannot be avoided in off-pump CABG, using a combination of clampless devices and the piggyback proximal anastomosis technique is safe, is reproducible, and can almost nullify the perioperative risk of clinical stroke. And the intraoperative TTFM demonstrated excellent flow rates, particularly when arterial grafts were used. And this technique is a good option when you have severe aortic calcification, but you still need to do a proximal anastomosis, and it will avoid two things: the Swiss cheese effect with multiple proximal hole, and moreover, also the piggyback configuration with an artery on vein can facilitate the use of more arterial conduit, like RIMA as free graft or a small radial artery, avoiding the effect of flattening of the anastomosis and the mismatch between the small artery and the aorta. Of course, further studies are warranted to confirm these long-term benefits. I'm happy to take questions.
Thank you very much for the comprehensive approach to avoid several infarction. It's very important. I prefer to use Encros 2, actually. Okay. To make our piggyback anastomosis, I think the heartstring might be, if you use a heartstring, probably you have to clamp the veins after anastomosis and put them. But the Encros 2, you still, on Encros 2, you can continue making a piggyback anastomosis. So because of that, I prefer to use Encros 2.
Yeah.
So how
actually, also in our practice, we didn't show this data, but 90% of the patients actually we used Encros 2. Okay. So only a small percentage of the patient we use heartstrings. We prefer to use heartstrings only when there are very heavy calcification, because you don't need to put anything into the aorta. You just do the hole, even if you have some more bleeding, because with the heartstrings you have a risk of bleeding, but we also prefer to use the Enclos 2.
Okay, and I use some clamp to hold the Enclos 2, and with the surgical arm, it's tightly fixed, and then it makes a second anastomosis very, very easy. So you have any kind of special technique? Just anastomosis, or?
Yeah, we do just anastomosis with the Enclos 2.
Please try it. It's very easy. It makes it easier for you.
Okay.
Okay, thank you very much.
Next speaker is Dr. Volkan Aleksic from Serbia. The title is Graft Options in Minimally Invasive CABG Total Arterial Revascularization from the mammary artery to the epigastric inferior artery. Very interesting.
Thank you for the opportunity to present our work. My name is Volkan Aleksic. I come from University Clinical Center of Serbia, Clinic for Cardiac Surgery. And today I present our experience with graft options in minimally invasive coronary surgery, focusing on arterial grafts. Coronary disease is one most widespread global health burden, driven by aging and modifiable factor risk. And minimally invasive coronary surgery increasingly important in treatment of multivessel disease, especially when we use arterial graft, which showed superior durability than venous graft. Our Siegel Center experienced cross-sectional study from October 2023 until March 2025 included 183 patients who underwent mixed cabbage operation. All conduits were harvested under direct vision in fully skeletonized fashion, mostly use harmonic hook type knives, scissors, and in small number of cases we use electrocautery. Depending on coronary anatomy, we use following grafts. Majority of patients in our study were male, in middle 60 with 27 body MI, and in every operation we use Lima. And in 67 cases, we use radial artery, proven to be was most commonly used as alternative conduits. Lima was harvested under direct vision with electrocautery and with ultrasonic hook type knives, and the time for harvesting is less in group with ultrasonic hook type knives. The Rima is also harvesting with bow technique and uses mostly as T graft, and the time also is less in group harvesting with ultrasonic hook type knives. You can see Lima and Rima. The radial artery was harvesting using non-touch bloodless technique to avoid spasm, and after harvesting we radial artery immersing in verapamil nitroglycerin solution. Harvesting radial artery is simultaneous with harvesting mammary artery, and in every cases, almost every case, we use as T graft for Lima radial artery construction. In 10 patients, we use right gastrocephaloric artery, and in our study, right gastrocephaloric artery has satisfactory length and diameter, and in all patients we use as an in situ graft with harvesting with ultracision scissors, also with non-touch technique. You can see this length of right gastrocephaloric artery. As additional conduit for total arterial vascularization, we use inferior epigastric artery in 6 patients. Also have satisfactory lumen and diameter in our patients, and we use semi-Feinstein incision suprapubic 2 or 3 centimeters above pubic, left or right. In all cases, we use as a T graft, and we have satisfactory patency on TTFM values. You can see it's part of the inferior epigastric artery. In our study, number of bypasses is ranged between 1 to 5 for total arterial revascularization of pump without touching proximal aorta, and CT after 3 months have excellent results. This minimally invasive off-pump total arterial CIBG represents a suitable options for multivessel coronary disease, particularly when multiple arterial conduits are available. Our experience shows that careful harvesting, gentle tissue handling, and the use harmonic scalpel and non-touch technique reduce conduit trauma and have good short-term results. And this research represents an ongoing study. Continuing follow-up will help to determine long-term patency and validate the durability of this strategy. Thank you.
So usually you use the T graft using the two artery graft.
Yes.
How do you put the anastomosis on the right coronary artery?
For right coronary artery, we must use for PD revascularization, and
From the same
in that case we use RGA, right gastrocnemic artery, for PD revascularization.
From same left thoracotomy.
Yes, from left thoracotomy. It's most difficult part to harvesting right mammary artery from left thoracotomy.
So just one question. So when you say that you are harvesting the inferior epigastric artery, so from a 3 centimeter incision, are you harvesting like under direct vision or with
yes,
the
under direct vision. And first we use prepare diagnostic to approximate length and diameter. Then we open the abdominal sheath of rectus, push the medial rectus abdominis, open the transversal fascia, and we explore directly inferior epigastric artery.
Okay, thanks.
Okay, thank you very much. Thank you.
Thank you.
So next presenter is Dr. Abidodin Arif Muhammad. Okay, thank you very much.
How do you think? Good afternoon.
Is this?
Yes. We go to presenters window. We are okay. Or directly we go there. Or
Okay. But this is okay.
Yeah. Thank you so much. Good afternoon, distinguished colleagues. I am Dr. Muhammad Abiduddin Arif from King Abdullah Medical City in the holy city of Mecca, Saudi Arabia. Today I'll be sharing our 10-year journey transitioning from open vein harvest to endoscopic vessel harvest technique. This evolution was driven by a focus on improving patient outcomes, enhancing recovery, and strengthening operative efficiency. Our data spanning more than 1,000 CABG cases highlights the clinical, operational, and patient-centered advantages of endoscopic vessel harvest while demonstrating its safety and long-term graft patency. Disclosures none. Why the conduit matters by endoscopic technique? Well, the learning curve is steep, but the advantages are immense. I won't delve into details about how it benefits the patients. Real-world evidence supports EVH cost benefits. The hunt for the smallest incision is on, whether in the era of mix, whether you do T-cab, mid-cab, robotic-assisted cabbages, you cannot justify a long incision for a staphenous vein or a radial artery. The main aim why this all came into existence is to provide a good quality conduit that is the future coronary of the patient at an affordable cost. My center is a leading tertiary care cardiac center in the western region of Saudi Arabia, serving a diverse and high acuity population, including Hajj pilgrims. Our cardiac program is built around international best practices, innovation, and patient-centered care. With historic timeline, the first EVH in our institute was performed way back in 2011. The objective of this study was to compare the outcomes with EVH versus open in terms of graft patency, wound complications, harvest times, hospital stay. We analyzed CABG surgeries performed between 2013 and 2023. This was the study design, a retrospective cohort study, CABG cases performed between 2013 and 2023 at our center. It included all adults who underwent isolated CABGs. Exposure groups were 2. The data source was collected from a review of institutional surgical records, operative notes, and post-op follow-up data. Variables collected was operative time, graft patency, wound complications, and length of hospital stay. These were the statistical methods that we used for analysis. Coming to the next slide, the annual CABG volume over the decade for our center. Our CABG volume steadily increased, crossing 400 isolated CABGs annually in recent years. The growth provided an excellent opportunity to track the evolution of our harvesting techniques. EVH adoption over a decade, the slide shows our transition from predominantly open harvest nearly a decade back to nearly complete adoption of EVH by 2020. 2019 onwards, EVH became the standard technique at our center due to team expertise and clear clinical advantages. Operational efficiency trend, the EVH significantly reduced harvest times compared to open technique. As the team gained experience, we evolved from the introductory phase, learning period, to the maturation phase, where we performed it consistently faster, more predictable, and workflow friendly. This slide shows the conversion rates. Conversions were very low and decreased to 0 over the past few years. This reflects improved technique, better equipment proficiency, and refined selection criteria. The leg wound complication rates, always the leg wound complications were consistently lower with EVH compared to the open harvest group. Open harvest showed higher infection and dehiscence rates every year. The length of stay gradually decreased in the EVH and remained consistently shorter than the open harvest group. Better wound outcomes and faster mobilization contributed to this improvement. The baseline characters of both the groups are in this table are well matched in age, gender, BMI, diabetes, and smoking status. Outcomes, the number of vessels harvested was similar in both the groups, but the operative time was significantly shorter in the EVH group. Coming to the graft patency, over a period of, after a long-term graft patency was comparable between the two groups, and this demonstrates that EVH does not compromise graft quality or durability. Well, this graphical comparison shows near identical patency rates across all the categories, whether EVH performs equivalently to open harvest and long-term graft patent integrity. In conclusion, EVH at our center has proven to be a safe, efficient, and patient-friendly technique. It has significantly reduced wound complications, shortened the operative time and hospital stay, and maintains excellent long-term graft patency equivalent to open harvest. Our experience shows that once the learning curve is crossed, EVH becomes an indispensable component of modern CABG care. Thank you very much for this opportunity.
So you like endovascular harvesting technique?
Yes.
Definitely. After 2021, only endovascular harvesting.
2019, yes, you're right.
That's right. So the patency rate is the same, and the wound complication is less.
Yes.
So anybody have any comment on this? Okay.
But meanwhile, if we use a vein, which should be very rare, we use no-touch veins. No? But this is difficult with endoscopic technique.
I didn't get your question.
When we use veins, no? We should use no-touch veins. No?
Yeah, I agree with you. This morning we had a presentation wherein we have a no-touch endoscopic technique also.
Really?
Yeah. Perivascular adipose tissue.
So I try not to touch, not to manipulate, and I can get the leg out in line.
Excellent, excellent.
I was just curious, with your team, who is primarily performing the endoscopic vessel harvesting?
Yeah, we have a bunch of residents. We have a training program for residents as well. And nowadays we have surgical care practitioners. So we have a blend of both.
Okay, thank you.
Thank you so much for the opportunity.
So final presenter is Dr. Hassan Fawd Alai Fawsil from Egypt.
Good afternoon. First, I would like to thank the organizing committee giving me the chance to represent our study, talking about the outcome of using radial artery as a second arterial graft in OPCAP. I have nothing to disclose. As we all know that there is a growing evidence supporting the utilization of the radial artery as a secondary arterial graft in coronary bypass CABG surgery. And this is coming in particular also in off-bump as well, And this study aimed to evaluate the clinical outcomes and experience related to the use of the radial artery as a second arterial graft in OPCAP. We have a total of 127 patients. It is a retrospective study done over the last 5 years. About 90 of them were males and 37 were female, with an average age is 65 years. This cohort has been using the radial artery as a second arterial graft. We have 28% of diabetic, 19 with a peripheral vascular disease, 54% in previous MI, and 58% was unstable angina, 30% was left main stenosis, and the Euro score more than 5 in almost half of the patient. The internal mammary artery has been used for all patients to LAD. Anastomosis regarding the radial artery, the proximal radial artery went to the ascending aorta in 39% of the patient, and to Lima as a T-graft in 75 patients, and to Rima in only 3 patients. While the distal anastomosis of the radial artery went to the BDA in 48 patients, and to OMs in 38 patients, and to RCA in 33, another and 8 patients to the BLV. The median follow-up of this patient was 5 years. Results: all patients underwent complete revascularization. The total number of all grafts was 330. The mean number of anastomosis per patient is 2.6, range from 1 to 5 grafts per every patient. Radial artery has been used sequentially in 55 patients. 7 patients required reoperation for bleeding, and 4 patients have perioperative MI. 2 of them went to CAS. 18 patients have renal insufficiency, and 9 patients has pulmonary complication. 1 case developed a stroke, and 3 patients have wound infection treated by debridement. Average ventilation time was 6 hours, and the ICU stay was 12 hours, and the total hospital stay was 11 days. Compared to the preoperative value, there was a significant improvement in CCC, Canadian Chest Society classification, as it went preoperative from 2.6 to 1.1 with a significant p-value. There was 2 hospital deaths, and the overall mortality in 5 years was 5 patients during the follow-up period. No ischemic complication was been observed in the arm where the radial artery has been harvested, and also there's no function disturbance in that arm as well. Postoperative ischemic event: we have 10 patients have developed postoperative chest pain. 2 of them required, as I said, to take him back to CAS lab, and there was a new onset of MI in another 2 patients. And actually, the 4 patients has been revascularized in the CAS lab. The reason for this revascularization in these 4 patients: 1 patient has a radial artery was closed, and the other patient have a radial artery string sign, and while the spasm in the radial artery happened in 1 patient, and hyperperfusion of Lima and radial artery in the 4th patient. Conclusion: the use of the radial artery as a second arterial graft in OPCAP bypass surgery improve outcomes. However, long-term outcome of these grafts require further validation through a higher prospective studies. Thank you.
So your graft configuration is almost literally and radial artery from the aorta or T-graft to the circumambulatory PDA. Your graft design is...
Yeah, it depends if we vascularizing the lateral surface of the heart, it goes to the aorta. If it will be extended in the BDA, we may be extended by the mammary and go around by sequential.
May I ask about the condition of the OPCAV in Egypt? How much?
Actually, I'm presenting this study from Saudi Arabia. I'm working in Saudi Arabia now. But OPBUMP is growing, yeah, as like in any part of the world.
So in Egypt, the Opcam is popular?
Yeah, become very popular, yeah.
Roughly how much percentage?
Almost 60% of BAM, 40% on.
Very good, thank you. Very interesting. Any questions from the floor? Yeah. Please, microphone, please.
Microphone.
Please.
You're using radial for sequential, marginal, and PDA.
As again, we usually having this radial to have bypassing a significant lesion in the native vessels, not less than 90%. So this usually depends on that.
You are using radial for this thing, sequential, marginal, and PDA.
Yeah.
So you are using a diamond anastomosis on marginal, or you are using a parallel one?
I didn't hear what.
Anastomosis is on OM is parallel or diamond?
On the diameter or what?
Anastomosis on marginal is diamond shaped or parallel?
Oh yeah, diamond shape.
Diamond, okay.
Okay, thank you very much. Thank you very much, everybody. And I could enjoy the very, the worldwide variety of the selection graft and techniques of the harvesting. Thank you very much for joining us. Thank you. So presented by Zarlene Parvis.
Yes.
From the title is a configuration harping techniques, harping technique and alternative conduits. So please start your next presentation.
Thank you, everyone. My name is Zareen Parvez. I'm a cardiothoracic physician assistant in St. Francis Hospital. I'm trained at Cornell. And then I've been PA for 24 years, and I've been doing this for that long. So I would like to present a study. We actually, at St. Francis, we started looking at doing this study, looking at the vein harvesting. So optical coherence tomography, looking at saphenous vein graft. We currently did a study based on, this is involved Dr. Lundy, Dr. Schlafmitz, Jeremias, and the study was based on pretty much we were prospective single center study. Imaging was performed, saphenous vein graft. We had about 27 patients, we looked at it. We currently have 700 patients enrolled in the study right now. We have met about 440 currently. So it's a study, pretty much what we did, we had a vein harvester. It didn't matter if it was someone experienced or non-experienced, they will get the conduit out of the vein. And once the vein conduit was out, we will use a technique, which I'll show you in a picture. We'll have that syringe with a bond check vein distension kit with the isolite solution, and we'll have a co-pilot attached to it. We will put a guide wire through it and trying to take imaging of ultrasound, looking inside the vein and making sure that the harvest that was done, if there was any intimal injury, if there was any intramural hematoma. So this is what pretty much we did. This study, we have a video, our PA who is doing vein harvesting at this time. We use this system currently we use is the Getting system because we don't use any other system. And we are actually one of the busiest programs in New York. We do about 600 plus or 650, I would say, coronary arteries. We can do anywhere from 8 to 10 cabbages. And we do endoscopically. I'm trying to promote to do more radial arteries. So I did bring our chief of cardiac surgery here yesterday, and after listening to that, Monday he booked a case with radial arteries, so I'm excited about it. So these were 26 patients were enrolled. Medium length were harvested on these cases of 43 centimeter. We did the medium length imaging time. They said it was anywhere from 8.5 minutes. Now it's 6 to 10, but I have to say, I've been there for almost 6 years. And our time of doing OCT study, it's gone to 3 minutes because it became so easy even for the technician, for the PA, for the assistant surgeon, or the assistant PA who's helping the surgeon. We know like the flow, what we have to pass. So from 8 minutes, we're down to 3 minutes. Again, we find during that 26 patient that we did, we find 22 minor abnormalities. 90 19 major abnormalities. And where we found the major abnormalities, if it was OCT guided, what we did, we eliminate that area and we picked the area that was good and put it on the patient's heart. Now, I'm going to give you an example. You took out a vein in front of you, you seeing there is an aneurysmal area, you can cut it off if you're unhappy with it. But if you see an area that looks pristine, but now you're doing endoscopy, you're looking through the OCT, and it's OCT guided, the tech is telling you, I just want to let you know this area segment such and such does not look good, has a clot in there, or there's an intimal injury. Despite it looks pristine from outside, you will get rid of that area. So this is what has been fascinating, I think, to be able to visualize inside the vein. The medium length of the OCT detected major abnormality has been 0.69 centimeters. The most highest was 1.1, and we will eliminate. And you can see those side branch-related injuries you were able to visualize in there also. These are the normal-looking OCT, and you can see the minor injury disruptions, and where the disruption was major, you can see there. This is intramural hematoma, no hematoma versus hematoma. This is normal versus sclerotic vein, major ones. We get rid of it if we see it. Fibrin clot, if we see it. So all our vein harvesting, we give 3,000 heparin. The moment we see we are about to do harvest, I make incision, I look at the vein, we give 3,000 heparin. So when I do harvesting, I have already given the heparin 3,000 while I'm harvesting. Important finding, intravascular imaging by OCT was technically feasible with excellent image capture. OCT identified that intramural abnormality within venous conduit in over 90% of the cases. These intramural abnormality did not correspond to external abnormality identified on visual, which I mentioned earlier. The magnitude of injury categorized as a minor or major could not be predicted based on the gross visual inspection of the vein. Lastly, interluminal abnormalities were predominantly focal and in close proximity to the side branches. Conclusion, vein graft failure remained one of the leading causes of increased short and long-term morbidity after CABG. OCT imaging harvested SVG easily identify possibly culprit of the vein graft failure. We show that external visual inspection for damage has no correlation with interluminal abnormality. OCT imaging can help guide us clinically. Co-registration, this is where we actually end up identifying, let's say we took the vein harvesting and we saw the vein was not great, then we have to figure it out to think the alternative conduit, if we have to take a REMA, we have to take a radial artery. Now, this was 26 patients. We are currently funded. Last 3 years, we got funded for $1.1 million. We have 700 patients planning to enroll. Currently, we are in 440, and so far we're doing well. And it's a 1-year follow-up with CTA and a 5-year follow-up. And these are the study that I was talking about, randomized, blinded versus OCT guided. And we also do, just to let you know.
Conclusion? Time is over.
Lastly, we do a flow probe just to do the measurement. So we measure the lima and we measure the the vein harvested, and then we measure the flow with it. That's it.
Okay.
Thank you.
Thank you very much. So maybe OCT is very costful. So is it just a usage for the study or just usage for the routine usage, just for the study?
We are just doing for this study right now, but we're hoping for future we can do in all the cases, and we can be able to test different, endoscopic vein harvesting. Okay. You know, instead of using just getting system, we can utilize Trumo and Venapex, and we can compare all three, harvesting.
And if the study showed a very good result, do you think we should use the OCT?
I think so.
Okay,
That's
final question.
extremely interesting. But do you have any preliminary observation of correlation of early failure or midterm failure correlated to the kind of disruption of the vein?
So we haven't had that data yet because we're working on it, but so far, like what we've been able to see, that was CT guided, we eliminate. So what it has shown, and the surgeon, he couldn't make it today, but the good part of it, literally, it does show you that what you see outside, not necessarily what is inside. So we were able to, the ones that we saw it was not good, we were able to eliminate, but the ones we not, I guess we're gonna find out.
Okay, thank you very much for everybody. Thank you very much.
Thank you.